Assalamu alaikum, everyone. Thank you so much for joining us. My name is Dr. Asma Akram. I'm the member of the scientific committee for this session, and I'll welcome you all here. I'll just let people settle down, and then I'll introduce. Thank you. Okay, I'll just kick off the session with the name of Allah Ta'ala. Bismillahirrahmanirrahim. Allahumma salli ala Muhammadin wa ali Muhammad. It's honor to welcome you all here in this session, and I hope you will all enjoy this learning experience. I'm going to start with introducing my esteemed guest here. Our chair of our session is Dr. Fawzia Khan, who has kindly joined us all the way from Karachi. Dr. Fawzia Khan is Professor Emeritus of Anesthesiology at Aga Khan University, Karachi, and founding member of its Department of Anesthesiology. Trained in UK, she has previously served as the department chair and interim associate dean for PCME. With over 200 peer-reviewed publications, she has received the Research Productivity Award of Pakistan Council for Research. And her research focuses on pediatric and neurosurgical anesthesia, as well as quality and patient safety. She currently chairs the WFSA Diversity, Equity, and Inclusion Committee and the Medical Advisory Board for Smile Train in Pakistan and the MENA region. Please welcome her. Thank you. Our co-chair of session is Dr. Huma Salim. She's a consultant anesthetist at Shaukat Memorial Cancer Hospital. With a career built on both compassion and precision, she brings together clinical expertise and a deep commitment to the patient safety, human factor, and quality improvement. A graduate of KE, Dr. Salim went on to complete her FCPS in anesthesiology and FCI from Ireland. Her pursuit of excellence didn't stop here. In 2024, she earned a master's degree in human factor and ergonomics from UK, reflecting her passion for understanding how people, system, and environment interact to shape safe and effective healthcare delivery. Please welcome Dr. Huma. Now I would request Dr. Huma to introduce and start with our first speaker. Thank you so much.
It's my honor and privilege to welcome you all to our session of Anesthesia for the annual Symposium of Khanum and introduce our esteemed guests for today. Our first speaker is Dr. Fawzia Banu. She is a consultant anesthesiologist in Ireland from Our Lady of Lourdes Hospital. She is a council member of the College of Anesthesiologists of Ireland and holds a fellowship in cardiothoracic anesthesia. She has a strong interest in regional anesthesia and is deeply involved in teaching, training, and innovations in learning through simulation. She has previously served as a lead for MCI examination and currently chairs the professional competence scheme as well. She will be delivering her talk on blended learning in anesthesia, integrating simulation with the traditional methods. Dr. Fawzia Banu.
Morning and assalamu alaikum, everyone. Thanks for inviting me, being a guest speaker here. So today I will be talking about the blended learning in anesthesia, a way of combining the strength of the traditional methods and safety of modern simulations. Over the years, the way we train the anesthetists has evolved. What used to be purely apprenticeship to the way to include the all modern anesthesia technique and structured anesthesia modules. This is Our Lady of Lourdes Hospital, Drogheda, where I am currently working as a consultant anesthetist. We are the regional hospital with the broad range of the cases, from the elective surgeries to the complex, the regional surgeries. Because of this variety, I recognize that the training opportunities can be variable. Some days in the hospital could be packed with the high-tech cases, while the other days are just the routine. So this made me understand how the blended learning methods are necessary. There is need for the structured training so that all the trainees get exposed to the same level of the trainees, and they know, what the methods are available and, what need to learn. So they get exposure to the variety of the cases, even if they don't have it during the day. So here, this all my concept came from. That's the council outside the hospital where I work. I'm chairing at the moment as as was being mentioned, as the chair of the professional competency scheme. The work of the professional competency scheme, mentioned that we need to be with, keep developing our professional development. Not only the trainees, but all the consultants need to be focused and developed through the structured training programs. So here all the concept came from. Now, beside that, I'm the mother of the 13-year-old boy who is neurodiverse. And I personally learned from him that the one side never fit for all the trainees, and we need to learn different ways to communicate communicate to the trainees and teach them in a different ways. So the one side, as I mentioned, doesn't feel. So we always try different methods to teach him, from swimming to bicycling. So here, give me the concept that one side is not fit for everyone. I have nothing to declare. However, I must thank to this little gentleman and my husband to spare me time to get involved in different activities outside my hospital and outside my routine works. So I'm really thankful to both of them. So what I plan today to cover, that we will start with defining what the blended learning is, what actually mean in anesthesia education, and then look at the role of simulation in improving both the technical and non-technical skills. Then I will introduce the College of Anesthetists, the CAST training program, and how the College of Anesthesiologists CAST training program get embedded into the national training scheme. And then I will introduce the strategies that help the Shaukat Khanum to implement the simulation as a training. The traditional training anesthesia is built around usually, the three main pillars that includes the clinical teaching, hands-on experience, and operating room. And these are incredible values. They allow the trainees to learn in a real time and observe senior clinician decision-making, and then gain direct experience from the anesthesia. However, there are the limitations for the traditional methods. The main limitation would be the time constraint. And if we look at the UK and Ireland, the working days are limited, and there is the European regulation to limit the working hours to 48 hours a day. So, and then again, there are the rare clinical scenarios and opportunities where not all the trainees get the same exposures. So that's why we need some, structured learning methods, and we need the simulation methods to train our trainees. There are the benefits why these, the traditional method and apprenticeship methods stay so long, because it provides the structure and the real patient interaction. There's immediate feedback, from the mentors, and there are opportunities to develop the professional communication skill. Learning directly gives the intuition to feel the patient and a clinical judgment, so that the trainees knows, what's coming in before even the monitor shows. So there are the benefits. So the blended learning means, using the mix-up of the in-person learning and with the digital or the simulation-based teaching. In anesthesia, this can look like, the classroom sessions for the core knowledge, and then the clinical rotation for the real life experience, and the simulation or online module for real case scenarios or the skill development. Blended learning is particularly useful in anesthesia because we all know our clinical environment is completely unpredictable. So it supports the flexibility. You can combine the real cases with the simulated one to ensure the full coverage of the curriculum. It increases the engagement through the video or the case-based discussion. And then, it's over the years, if we can look at it's cost effective, and all we need initially is to develop a good scenarios, which can develop the confidence and competence, to manage the evolving challenges that needed in the future. So why the simulation is and why we are looking at is not only the anesthetist who are looking at the simulation, it's not only the medical field. Our best, parallel is the aviation industry. The pilots, they don't usually wait to face the real mid-air emergencies to learn what to do. They practice hundreds of times, and it's all the simulated emergencies until the correctest response becomes automatic. Similarly, we face a lot of complicated cases. There are rare cases like malignant hypothermia. It's one of the example, and another example is anaphylaxis, which we don't feel it day to day. Massive hemorrhage, not every resident face on day-to-day basis, but those cases when happen in real time, we need a coordinated, corrected, and confident response. So when we adopt the simulation, what happens is when these situation occurs, there is a coordinated response, there is a confident response, and the decision making is faster in comparison if they don't have faced these situations. Simulation and the patient safety. It's the safety is the biggest thing where the simulation really matters. It gives the trainee a chance to make mistakes, they reflect on, and they correct themselves without any risk to the patient. So simulation also helps to cover the system level gaps. For example, how team responds, in the emergency crisis. There are other papers that shows the benefit. The team, those who are being trained doing the simulation, and when they are working together in the real life, they do less mistakes. Their response are always coordinated, cohesive, and they do make the decision on time. As I mentioned, the evidence base for simulation is really very strong. Studies have shown that it improves the success rate in complex procedures, such as regional anesthesia and the vascular access cases, and they reduce the complication rates. The team trained together, again, they perform much better during the crisis. And then the long-term effect, the studies have shown those who are exposed to the simulation, who are trained with the simulation, they retain them for a long time. Their responses are still valid for the longer time as compared to the classroom-based teaching. The non-technical skills that also improve. The anesthesia, we all know, is not only managing about the physiology, also managing the people as well. So non-technical skills like communications, the teamwork, the situation awareness, and the leadership, they all are critical. The concept of the crisis management was originally arise from, again, the aviation, that how the team respond, how to respond to the crisis once it's happened. So the simulation improve all these responses once it happens. The simulation modalities, you don't need, doesn't need to be high tech initially, doesn't need to be, very expensive. There are you can start with the low fidelity stimulation, which might involve, a simple manicum or task trainers. For example, we have in our small department simulator that where we can teach them how to do the central lines and how to start with the epidural for the beginners. So it really helps them, they can come back, keep repeating the task until they are confident before they are going to attempt the epidural itself or before attempting a central line on the real patient. So we don't need the expensive simulator initially. We can start with the, anyone can start with the low cost, simple manicum, which are usually called as a task trainer. Start with them and give the confidence to the trainees to start the basic task and then go from there. Even the Royal College of Anaesthetists have published the guidelines, for that. All the procedure guidelines, how to start the case, and these simulation modalities to be included in the trainees. Then we involve the medium fidelity simulators, which have the basic response to the normal physiology like breathing or replicate the the heart rate, and these things are the vocal cords. So these basic manicums can also help. These are the medium fidelity simulator. They can, the starter can start with this one, and then the high fidelity simulator, which can replicate the whole body response, the response to the drugs, respond if you are giving any drugs, how they are going to respond, So it's the same man which can give you the whole response. These are the high tech, expensive ones. And then there is the virtual reality or the screen-based simulation, where you can develop the scenarios. You can make there are the actors. You can task trainers and the actors. You can have it where they can give you a response. So simulation can be started even without the mannequins, where the actors or the trained doctors can give you the response rather than the mannequin to start with. So these actors can help, the only we need it is a well-structured scenarios to start with, that what the response would be and how you are going to improve yourself. So start with the actors. These actors are mostly helpful for the communication skills, how we communicate or how we improve the communication skills in our trainees, or they are also good for, train our trainees for any outpatients, how to take the history from them, or, so these actors are also helpful for start simulation. So in the College of Anaesthetists, the College of Anaesthetists simulation training program was started in 2010, and initially it offered the optional courses, but then with the strong outcome and the positive feedback, it becomes a core component of the national training program. Now it delivers over 60 courses over 3 hospitals, including the Galway, Cork, and Dublin hospitals, and these core courses include the anesthesia emergencies, airway crisis, adverse events. The most important is the mascot, which share the crisis scenarios between the different specialities. Here, this mascot course involve the emergency medicine doctors, the surgical doctors, the nurses, and anesthetists. They are all together. And here we develop how the multidisciplinary team can act together during the crisis and how they are going to respond during the crisis. So impact of the cost. or the in the College of Anesthesiologists has completely changed how the anesthesia training is structured there. It's now fully embedded in the national curriculum and contribute to the measurable outcome. So how we can implement simulation in the anesthesia training in here. So first is to dedicate a simulation space is essential audiovisual support and manicum. Then again, start with the low to the medium fidelity models. Then develop the faculty through the trainer courses so that the hospital is not dependent on the few people, and then develop the curriculum, begin with the anesthesia emergencies, and then add on to go further on the intensive care or the pediatric simulation. Then collaborate with international hospitals or the training bodies like College of Anesthesiologists to cast how they develop, especially for their templates to develop the scenarios. How did they develop the scenarios? And, what is the debriefing is? So, which is the most important thing? And always develop the scenarios which are important to the local patients, like, Shaukat Khanum has a lot of oncology patients, and they have, what the oncology patient face, what could be the crisis in them if they are developing sepsis, what are the causes of sepsis. So, just with the help of what the local caseload is, develop those, and then, start with the pilot courses, and then scale to become the national, So my understanding is the Ahan Hospital also is having the simulation center there. So collaborate with them, those international and the national center, and then start with the pilot courses and then go from there. In future, a dedicated simulation center of excellence could serve both as a training and the research hub in the Shaukat Khanum Hospital. It could integrate the blended learning, which can combine the e-learning module with hands-on simulation to improve the retention and accessibility. So to conclude, the traditional training method remains the foundation of education in anesthesia, but is no longer, sufficient in its own. Simulation complemented by providing the structure, risk-free and consistent opportunities for learning. It proves both technical and non-technical skills, and it promotes the culture at the end of the day for the patient safety. Thank you.
Thank you very much, Zia, for the excellent talk. We'll have the question and answers after the three talks.
Thank you, Dr. Fauziya. And now I take this opportunity to introduce our next speaker, Professor Saida Asif, who is the Professor and Head of Pediatric Anesthesia at the Children's Hospital, Lahore, and Pediatric Anesthesiologist at Nationwide Children's Hospital, Columbus, Ohio. She has extensive experience in pediatric cardiac anesthesia, difficult airway management, and leads a lot of quality improvement projects, especially in resource-limited settings. Today, she will be delivering her talk regarding anesthesia for congenital cardiac patients with congenital cardiac disease undergoing non-cardiac surgeries. Dr. Saida Asif, please.
First of all, it's a disclaimer. I'm a pediatric anesthesiologist. I do not claim to be a pediatric cardiac anesthesiologist. I do practice pediatric cardiac anesthesia for the past 15 years in Pakistan out of quite necessity. I'm going to quickly start talking. I hope at the end of this talk, there are a couple of things that you should be able to say. You should be able to understand the morbidity and mortality associated with congenital heart disease in patients undergoing non-cardiac surgery. Identify the risk factors associated with the higher risk of morbidity and mortality in these patients, develop a plan, and identify the key principles of management in single ventricle physiology, pulmonary hypertension, and left ventricular flow outflow tract infection obstruction. And at the end, if I have time, then I'll just go over very briefly with congenital heart disease in Pakistan. I don't have any financial disclosures. So more than 90% of children born with congenital heart disease are surviving into adulthood. In fact, in the United States, there are more adults with congenital heart disease than there are children with congenital heart disease. So this is a significant change. All of us, even in the adult world, who probably don't care about congenital heart disease, will have to learn about congenital heart disease because these patients are going to be coming to you for different kinds of surgeries. Mostly congenital heart disease is an isolated lesion, but about 30% of these patients have some associated extracardiac abnormality. And following cardiac surgery in the first year of life, about 40% of them have at least one non-cardiac procedure under the age of 5. So this is a recent, sorry, hang on one second. This is a recent analysis. This is data out of Pediatric Health Information System. This is a 52 hospital consortium. They all supply their pediatric data. And out of that, they looked at patients who had congenital heart disease and were undergoing non-cardiac surgery. So you can see from 2015, from 38,000 patients, this number has increased to almost 46,000 patients. The good news is that, I'm very sorry for this slide. You can't really read very much out of it, but the most common 2 procedures are either ENT or GI related surgeries these patients undergo. The good news is despite the increasing volume and complexity of the congenital heart disease patients that we're seeing, the mortality was 1%. It really hasn't increased. But that's not true historically. So if we look back at the data, at the initial data, so this is actually out of Victor Baum's, and this was a hospital consortium, and they looked at, I can't remember, I think 1993 to 1996, it was about a 4-year study. They had about 200 patients, and they looked at what was the influence of congenital heart disease after non-cardiac surgeries. And they found that in all these pediatric patients undergoing non-cardiac surgeries, there was an incidence of 6.5% had congenital heart disease. They wanted to see how it made a difference on short-term mortality and 30-day mortality in neonates, infants, and 1 to 17 years of age. So if you look at 30-day mortality, children with congenital heart disease had a 6% mortality compared to almost 4% if they didn't have a congenital heart disease. But this was markedly different. If you were a neonate or an infant with congenital heart disease, you had twice the risk of dying from the same procedure or surgery if you didn't have a congenital heart defect. So if we look at another database, all the hospitals who take care of children provide their perioperative cardiac arrest to this registry that was formed, I think, in 1992. The Pediatric Perioperative Cardiac Arrest Registry, and I understand there are a lot of people here from Ireland and UK. I'm very sorry, I'm very US-based, so all the data I'm going to present today is going to be US-based. So from 1994 to 2005, they reported 373 cardiac arrests in children. And out of these, 127 had congenital heart disease. And 33, their mortality rate, so if you have a cardiac arrest and you have a congenital heart disease, you're much more likely to die than if you did not have congenital heart disease. Now, the other interesting thing, if you look at this, was 54% of these arrests were in the operating room, in the general surgery operating. Only 26% were in the cardiac operating, and 17% were in the cath lab, which I would say is so. What it basically tells us is that what we need to focus on is in the general operating room. That's where these kids are dying. Randall Flick published data from Mayo Clinic, and they looked at perioperative cardiac arrest over a 5-year period from about 93,000 patients, cardiac patients who were undergoing non-cardiac, or actually all patients who were undergoing surgery. And they reported 26 cardiac arrests in children. And in their cohort, again, we see the same thing. 7 of these cardiac arrests were children with congenital heart disease. The most common reason for cardiac arrest in children with congenital heart disease was hypovolemia, either because of hemorrhage, or hypovolemia because of hemorrhage, or hyperkalemia from massive blood transfusion. This is probably true for kids who are smaller and required more rapid blood transfusion. So moving on to data from Boston Children's Hospital, Lee looked at about 3,000 patients with congenital heart disease that were undergoing non-cardiac surgery. And they wanted to see what kind of adverse effects these congenital heart disease patients were having. So the most common cardiovascular event was cardiovascular event. It was about 11.5%, followed by respiratory event, which was 4.7%. So who is at higher risk for having these complications? So if you are a sicker patient, an ASA 3 or more, if it's an emergency surgery, if you have major or severe congenital heart disease with some residual lesion, poor functional status, single ventricle physiology, or if you have ventricular dysfunction, your chances of having cardiovascular event are higher. Now, when we look at respiratory events, these are the kids who are sicker, usually ASA 4, ENT, GI surgery, general surgery, and maxillofacial surgery. And the cardiovascular events were associated with the underlying disease, but the respiratory events were not. So basically, they were dependent on what kind of surgery they were getting done. If we look at congenital heart disease in patients undergoing outpatient surgery center, if you have major heart disease, these 1,000 patients out of this previous cohort at Boston Children, they were much more likely to get admitted postoperatively, even if they were having a minor outpatient surgery. So how do we define risks in congenital heart disease surgery? So the American College of Surgery has this National Surgical Quality Improvement Program, and all the hospitals give their data to this database. And they define congenital heart disease into 3 categories: minor, a cardiac condition that may or may not require medication, such as an ASD or a small to moderate VSD without any symptoms, or a repaired congenital heart disease with normal function and no medication. They define major as a repaired congenital heart disease with some residual hemodynamic abnormality with or without medication. So for example, if you have a tetralogy of fellow coming in that has a free PR, so that would be a major risk category. And all single ventricle physiologies, for example, hypoplastic left heart syndrome, including if they've had stage 1 palliation done. Severe cardiac heart defects were defined as uncorrected cyanotic congenital heart disease. So if you have a NSQIP classification, and they looked at a cohort again out of the NSQIP database and compared 4,000 patients with and without these 8 categories. So these 8 factors that they identify by comparing these 2 cohorts were to predict the perioperative outcomes with good correlation was if the patient was on mechanical ventilation, had acute or chronic kidney injury, or had required CPR, pre-op CPR. So they gave them a score of 4, 3, and 2 respectively. If they were getting an emergency surgery, if they had severe congenital heart disease, single ventricle physiology, or had cardiac surgery within the previous 30 days, or were on inotropic support, each one of these got a number of 1. And I'm really very sorry, but the journal wanted $100 to put this in this presentation and $150 to register. So here is my boring slide for this. But if you have, so look at these previous risk factors. And if you compute a score of less than 3, you have a low risk of mortality. If you have a score of 4 to 6, you have a moderate risk. And if you have a score of 7 or more, your chances of mortality are significantly higher. So this is also one of the ways, I know this probably doesn't correlate here, but in the United States, if you have, let's say, 20 pediatric anesthesiologists in your group and 4 cardiac anesthesiologists, there are a lot of patients with congenital heart disease. Who takes care of these patients? So some centers are using this criteria to kind of decide the sicker patients are going to go to the pediatric cardiac people, and the rest of the group is going to come to the general pediatric anesthesiologist. So if we live in an ideal world, all non-cardiac surgery, non-elective, non-cardiac surgery should be deferred if possible till the cardiac lesion is treated. How many here have actually taken care of a kid with congenital heart disease that has not been treated? Can anybody? Yep. 2 people?
Shy.
Hmm?
They're being shy.
So the truth is that sometimes these kids require emergent or urgent surgeries. You don't always have the option of waiting for them to be repaired. Trust me, if you work in Pakistan, you will see an unrepaired tetralogy, an unrepaired VSD with pulmonary hypertension, unfortunately, on Eisenmenger, even with an AST. So they can come in either for surgeries related to their other congenital abnormalities, or if they're adults or adolescents, then they might come in with trauma, pregnancy, cancer, or cholecystitis. And you have to decide, okay, who is going to do it, where are we going to do it, and when are we going to do it? So if it's an emergency surgery, you're not comfortable, call up somebody who does this regularly. So this is, again, out of the Ferroni algorithm. If you want to look it up, I've got a reference at the end. You can go back and read that article. And you can consult a cardiac anesthesiologist and go and make a plan with them. If it's an elective surgery, you can say, okay, if this is a minor, major, or a severe risk category, this is their age, these are the comorbidities, and this is the kind of non-cardiac surgery. So this is why we're going to proceed. And if it's a minor cardiac lesion and there's no need for an ICU bed, you're pretty safe to proceed. If it's a major cardiac lesion with a risk score of 3 or less, you're still much safer to receive. But for major cardiac lesion, or if the risk factor score is more than 3, if they have single ventricle physiology, it's best to go ahead and either refer them to a center that takes care of these cases regularly, or call up somebody who is able to provide these backup services. Now, like I said, about a third of these cases have some genetic abnormality like key fistula, anorectal malformation, or it's not uncommon to find genitourinary or musculoskeletal deformities in these patients. So your pre-op evaluation is very, very important. A couple of things you want to know. What are their presenting symptoms? What is their cardiac status? So, when these patients come, you look at the echo, you look at their cath lab, they usually have an anatomical diagram. So try to take a look at it, even if it doesn't make any sense to it, and try to figure out what their pathophysiology is, function is, what kind of intervention that they've had, and what their present management is. The other thing you want to really find out is how about their recent respiratory illness, because this can really take up their PVR and have an impact on their perioperative mortality. If they've had previous anesthesia, were there difficult intubation? Was somebody able to get a PIV easily? How was their ICU care? And then what's the impact of the non-cardiac surgery on the underlying pathophysiology, and do they require endocarditis prophylaxis? Quick things, couple of things. In a lot of congenital heart disease, I want you to really look at their baseline arterial saturation. Just go ahead and put a pulse ox on. Because in some of these patients at 70s to 80s, sat is normal. That's what you want them to be. You don't want to drive, we're used to seeing everybody with 100% sat, and we give oxygen if they're not 100%. That may not be the best thing for all these patients. If they have a history of aortic arch repair, or if they have a BT shunt, then you should get a blood pressure in more than one extremity. If they have had a BT shunt done, you're not going to have the same, your blood pressure may be lower. So you may think, oh my God, there's something wrong, they're hypotensive, and you might initiate therapy when all we're doing is taking the blood pressure in the wrong arm. Identify your sites for vascular access. These kids usually have had a lot of procedures done, and vascular access may not be the easiest one. And you also want to see where you're going to place an arterial line if you're going to put that in. If you have any studies and you want to look at what is it that you mainly want to look at? You want to see what their ventricular function is like. If they have any AV valve or semilunar valve dysfunction or regurgitation. If they have a shunt, is that working? If is there any severe systemic outflow tract obstruction? And these kids can frequently have liver, renal, or pulmonary disease. So try to establish what their baseline is. If they're cyanotic, there are a couple of reasons they might be cyanotic. Either there's not enough pulmonary blood flow. So they may have pulmonary artery stenosis, there may be a shunt stenosis, there may be a collateral. A lot of these patients, despite having a shunt, develop collateral decompression, and that can actually decrease flow through the shunt, and you develop cyanosis. They can also have intrapulmonary shunting or VQ mismatch, or they actually may have low cardiac output syndrome. So try to figure out if they're cyanotic, what's the reason for their cyanosis. Chest X-ray is very helpful, not only because you can look at the heart and the lungs, but you can also I think in my opinion, more importantly, check out if there's a pacemaker or an ICD. If they have leads, if they're in right position. It's a bad thing to be surprised by leads that you didn't know and by pacemakers that you didn't know were in place. Okay, I'm going to go through this very, very quickly. So if a pacemaker and ICD, just figure out, are they dependent on this pacemaker? If so, you need to get this interrogated, and you need to go ahead and get this reinterrogated at the end of the procedure. Arrhythmias, let's move on. I think main thing, couple of things. Fontaine physiology.
Please continue. It's all right. It's all right.
Sure?
Yes, please.
Okay. I will take 2 minutes of your time.
No worries.
So these are the conditions basically where there's loss of rhythm. There's loss of cardiac output. So you don't want to lose. You want to maintain their normal rhythm. It's really important. You don't want to distend their atria or their ventricle. You want to avoid acute hypoxemia. And you want to be able to pick up any electrolyte abnormality because they're just so prone to arrhythmias. A couple of conditions that I really am always worried about that they're at risk for developing arrhythmias is Fontaine, CCTGAs, and Epstein's. And unfortunately, you'll see a lot of these in Pakistan. So you have to be prepared to treat these arrhythmias. Please place your pads ahead of time. Because when you need the pacing or when you need the cardioversion, you want to have the pads in the room or on the patient if required. And the medications available to you. You shouldn't be running around to see if you have medication at the hospital. Other couple of things, I always look at their potassium, especially if they're on diuretics. It's not uncommon, unfortunately, in Pakistan to come across tetralogy with a hemoglobin of 20 and a hematocrit of 60. This is not normal. You can also pick up their other abnormalities. Always look at their liver function and their renal function test. If they're on anticoagulants, you obviously want to follow that up. You also want to time when do you want to stop? When can you stop their anticoagulation? And at that time, it's really important that you talk to the cardiologist and to the surgeon and time the anticoagulation accordingly. There are two sides. All these cyanotic kids have underlying coagulopathies. So they're very prone to bleeding. And on the other hand, they're also prone to thrombosis. So Fontaine physiology, I'll go over that very quickly. Chronically elevated central venous pressure. So because of that chronic central venous pressure, they have associated liver disease, and they also have coagulation abnormalities. You also see this in cyanotic heart disease and in single ventricles. Now, the other thing I really want to caution is we have a lot of kids coming in, especially in Pakistan, who have had BT shunt done. Now, a BT shunt basically is a shunt between your subclavian and your pulmonary artery. And this is the sole provider of pulmonary blood flow in some of these patients. If you stop the anticoagulation, if these kids get hypotensive or hypovolemic, the shunt shuts down. There goes your pulmonary blood flow, there goes your cardiac output, and all of a sudden you land yourself in a patient who's blue, hypotensive, and you don't know why. So you want to make sure that they're well hydrated. If you are going to stop their anticoagulation, you talk to the surgical team and you guys have a plan for that. Most of the centers, if they are anticipating a prolonged fasting, will stop their diuretic. Most centers, we discontinue ACE and ARBs 24 hours prior to the surgery. I don't think this is any different than what adults are doing. Low-dose aspirin, again, we continue for superficial cases, but we withhold that for 5 days or more for major surgery. Patients who are on warfarin, especially if they have a valve in place, are admitted ahead of time and converted to heparin therapy as a bridge. Laparoscopic surgeries. I don't know how many of you are working with surgeons who are doing laparoscopic surgeries. Laparoscopic surgeries, particularly in single ventricle physiology, in Fontans, in Glenn's, or stage 1 palliative, can be very challenging. So I talked to the surgeon ahead of time. I asked them, what pressure are you going to use? If you talk to them, I've found them that they're generally very helpful. They will say, okay, we will start with this pressure. They will communicate. They will start at a lower pressure. They're not going to take the pressure directly to 12. So if you start 4, 5, keep going, you tell them how the pressure patient is tolerating. And so, because the minute you insufflate the intra-abdominal cavity, your venous return decreases. And these patients are very, very dependent on their venous return. They do not take that very well. So single ventricle physiology, one second, here we go, is a lot of different conditions ranging from hypoplastic left heart to severe neonate aortic stenosis, pulmonary atresia, intact ventricular septum, tetralogy with pulmonary atresia, truncus, tricuspid atresia, double inlet LV. They all have one thing in common. They may be morphologically different, but physiologically, they're all the same. And what's common is that in a normal heart, all the deoxygenated blood comes into the right heart and gets pumped by the right ventricle into the pulmonary artery, goes through the lungs and comes back into the left atrium and then is pumped out from the left ventricle into the aorta. This is called a series circulation. You come and one after the other, 1, 2, 3, 4, the deoxygenated blood will come back, get oxygenated, and then will be pushed out to all the organs in the body. In a single ventricle, what's common about these is the pulmonary and the systemic venous blood will come and mix at the atrial or at the ventricular level. And then either a single or 2 ventricles will distribute it to both in parallel to the pulmonary and the systemic circulation. The other thing that's common in these lesions is, and so the blood flow depends on the relative risk. So whether how much blood is going to go to the body or how much blood is going to go to the lungs, QP and QS, it really depends on resistance to the flow. So if your pulmonary circulation has higher resistance, more blood is going to go into the systemic circulation. The systemic circulation has a lower resistance and pulmonary vascular resistance is more blood is going to, so you're going to have somebody who is getting so little pulmonary blood flow, but is hypoxic or desaturated, and but their blood pressure is normal. So the flow to the pulmonary artery or to aorta has some variable obstruction, either at the inlet or outflow or on both inflow and outflow tracts. So the saturation because of the mixing is normal, 75 to 85. That's the normal. When we look at, so why is single ventricle physiology so important? It's so important because this is a relatively unstable circulation and it has intra-op early and delayed. Adverse events in non-cardiac surgery is 12%. You remember from the previous we looked at, it was 6% from the older data. In this cohort, it's 12%. From the POCA registry, 13% of these children had single ventricle. So I'm not going to go over the initial palliation. What I do want to discuss is the two things that these single ventricle physiologies, they get 2 procedures generally speaking. One is called the bidirectional Glenn or the superior cavopulmonary shunt, in which you take the SVC, disconnect that from the heart, and directly sew it to the pulmonary artery. What that does is, so now all your, okay. ये कितने का time था? अच्छा, okay, let's just do this very quickly. I think if anything that needs, your goal with ventilation for a bidirectional Glenn is you want to have mild respiratory acidosis. You want to have some degree of entitles you to be higher, so that you have increased cerebral blood flow. Increased cerebral blood flow increases flow through the shunt. If you remember, all the blood flow is coming through the SVC into the PA. So when we increase cerebral blood flow, these are not the patients that you want to hyperventilate. Please do not hyperventilate. Now, the goal is also to keep our PVR low. This automatically increases our PVR slightly, but to offset that, keep your mean airway pressure low. These are preload dependent, so give them some volume. Fontan, same thing. There is no RV. There is no ventricle pushing your pulmonary blood flow. This is all passive blood flow. So you want to keep your pulmonary blood flow going forward by having a high central venous pressure, lower PVR, and a lower left atrial pressure. So Fontans are, generally speaking, one of my attendings used to say, I'll give them fluids. You can't give them enough fluids. So if you're in doubt, give Fontans some fluid. Give them a 5 or 10 ml per kilo bolus. Ideally, you want to keep them spontaneously breathing, but I'll tell you what. If you have a patient who's inadequately spontaneously breathing, I would rather that you do controlled ventilation with low mean airway pressure. So for me, that usually means I give a bigger tidal volume, 8 to 10 ml per kilo, and keep the respiratory rate less, somewhere between 12 to 820 per minute. I'm going to skip over everything else. I think the one thing I did want to say, if you have post-operative hypotension, it's usually multifactorial. You've given them some anesthetics, their underlying cardiac lesion, some degree of hypovolemia. It's usually a combined mixture. So when you see this, give them a fluid bolus, consider a vasopressor earlier on rather than later. And you especially want to think about some dextrose containing fluids for neonates and young infants. So how many centers do you think there are in Pakistan? My population kitni hogi hai? 2. So we have about 16 centers. I think 5 or 6 of them are in Lahore. We have about 10 in Punjab, and the rest 6 or so, about 4 I think in KPK, 2 in Bindi. So you can see the distribution is very, very regional and central to big cities. As somebody said, so I work at Children's Hospital. We do about 1,100 or so cases a year. In Lahore, I can tell you that there are about 3,000 to 4,000 of these surgeries. If you look at these numbers, if I tell somebody in the United States we're doing 1,100 cases, and I'm only including, this is not cath lab, this is just cardiac ORs. We are right up there with the top 3 cardiac centers in the United States. I think Emory probably does about 1,100. So it's a large volume. But unfortunately, every year we have 40 to 60,000 children born in Pakistan with congenital heart disease. This is a huge improvement. 20 years ago, everybody who had a congenital heart disease, the cardiologist would say, India chale jao. Now we have 16 centers in Pakistan, alhamdulillah. And this is going to increase. And so when they insisted that I should give this talk on congenital heart disease, I said, okay, I'll do it because I think all of you are going to see it more and more. Thank you.
Thank you so much. Thank you. Thank you so much.
Review of children with disease undergoing contact. आप ही वो क्या उर्दू में कहते हैं ना दरिया को पूजे में बंद करना, हाँ वो कह रहे हैं. Thank you.
I take all the blame because I insisted to Dr. Fawzia to do this talk, and thank you so much for doing this again. Thank you.
So for our next talk, I'm going to invite Dr. Baloch. He is a full-time pain consultant at Firmly Health NHS Foundation Trust, Surrey, in United Kingdom. He leads the pain service over there, and he's also an examiner of the FFP MRCA and serves as the regional advisor for pain training for the Oxford DB. He will be presenting his session titled Shouldering the Burden, a practical approach to the diagnosis and management of shoulder pain. Dr. Baloch, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much once again for inviting me back to Lahore, one of my favorite cities in the whole of Pakistan. Special thanks to Dr. Almas for the invitation and Dr. Asma for being amazing at looking after me whilst I've been here during my stay. I have to say, organization at SKH in terms of organizing conferences is the best in the world. I've not seen better than this. So congratulations. Right, so my task is really to beat the bell this time because I could talk for hours on this subject. Why? Because I used to be an anaesthetist. I'm an expired anaesthetist. I stopped giving gases 3 years ago. My sole job actually for the few years before I gave up was as an anaesthetist for a military consultant who just did shoulders. So I did lots of anesthesia for shoulders. And then of course I saw patients that were suffering with shoulder pain. And a lot of my work involved looking after these patients that couldn't have surgery for one reason or another. And what I'm going to try and do as quickly as I can, because it's a massive subject, is to take you through my journey in the pain world, how I came to do the various interventions that I do for pain. I hope that's okay. Conflict of interest, I used to teach on some of the courses run by Abbott, which is one of the radio frequency companies, but I didn't get paid for that. Right, so what am I going to talk about? I'm just going to recap the anatomy. I think it's quite important when we talk about shoulders, just to understand the structures that we're dealing with. We'll look at diagnosis as well, and then we'll look at some of the interventions that I do and how I got to do what I do now. Shoulder pain is a big problem. It's the number 3 MSK pain in the world after back pain and knee pain. These are global figures. They're not specific to the UK. Has anyone had shoulder pain, bad shoulder pain? Yeah, the hands are, so they actually recovered shoulder pain because your hands are going up. Yeah, so I've had frozen shoulder on both sides. I can tell you it is crippling. So your shoulder is the most movable joint in the whole of the human body. If you can't use it, you're literally crippled. So the burden is immense. Now, fortunately, 50% of patients with shoulder pain get better spontaneously with conservative treatment. That's the good news. Big set, my sort of age, middle age, more in females than men. And of course, your occupation has a role, as does genetics, as with many of our pain conditions, and clearly lifestyle as well. Presents in different ways, depending on what sort of condition it is. And we'll talk about the different types of reasons that people develop shoulder pain in terms of specific conditions. Like with everything in pain, it needs an MDT approach. It's not about me sticking a needle into someone. You know, I work with a shoulder surgeon, I work with a shoulder specialist physio, OT, nurses, and pain psychologists. So it's an MDT approach for the management of the pain once it becomes chronic. Okay, so we said we'd talk about the causes. I'm not going to go into, the biomechanics of all of these individually. I'm sure you've heard all of these conditions. They present in different ways. I mean, the rotator cuff, typically, elderly patients fell on the floor with an outstretched arm, so sudden onset. Adhesive capsulitis could be after an injury, but can't move their arm at all, severely painful. OA is a more gradual thing. Doc, it gradually started getting more and more and more painful as I started moving it, and so on and so forth. What I've put down here in the corner, as you can see, is cervical spine. The reason I've done that is that so many times patients come to me and, Doc, I've got shoulder pain. Okay, so where is it painful? Over here, doctor, this is my shoulder. And actually, when you come to examine them, the pain is coming either from the trapezius or is referred pain from up here in the neck, from the cervical facets. So obviously, examination, very, very important. Just because a patient thinks it's the shoulder. When you ask 100 patients, where is your heart? The point is right in the middle here. The patient's understanding of anatomy is obviously not correlated with how we understand anatomy. So the only one I didn't put down here, I'm given that this is an oncological conference, is metastatic shoulder pain. And the reason I didn't put that is I hardly ever see it sent to me. That goes to the radiotherapist. Because really, the stuff I'm going to show you, when I've tried it in the past in terms of interventions, it doesn't touch it. Either it's a pathological fracture, they need surgery, palliative surgery, or do they need radiotherapy? These blocks really don't do very much, and we'll talk about that later. Right, there's 1,000,001 tests that you can use to try and work out what the underlying cause of the pain is. The empty can test is an easy one, outstretched hands, you're emptying your Coke can downwards. The supraspinatus, Hawkins-Kennedy, shoulder at 90 degrees flexion, elbow at 90 degrees flexion, downward movement, and so on and so forth. Why have I put these there? Because when you see a patient with shoulder pain, you need to have some idea of where you're going to send them for a definitive imaging. Because really, we nowadays make the diagnosis on history, yes, examination, but on the imaging, ultrasound, X-ray, or MRI. And if it's a labral tear, really you need an MRI. If it's a cuff tear, ultrasound. If it's OA, X-ray. If it's a tendinopathy, possibly no imager. So I put those there just so that it gives you an idea of where to refer these patients in terms of imaging. Right, okay, so anatomy of the shoulder seems very straightforward. It's actually quite a complicated structure because of the nature of its range of movement and so forth. A common culprit, of course, is the glenohumeral joint. The majority of your pain is going to originate there. But of course, there are other joints there, the AC joint. That can also cause a problem as well. And then you can have various dysfunctions around the scapula. And of course, this whole structure is surrounded by the rotator cuff. You've got biceps over here with its own tendon, and biceps tendinopathy can also present with shoulder pain as well. What I want to do is focus on the nerve supply, because that's really my interest in terms of pain. And what this is a consensus study. They looked at about 61 anatomical studies looking at the nerve supply of the shoulder joint. And the thing that we're interested in is the red, these areas here, because those show the density of the nociceptors, our pain receptors. And what I want you to do, if you possibly can, is remember the nerves that have the greatest nociceptor supply to the shoulder joint. Now, subacromial space has the highest number of nociceptors, and that's something that we're not surprised about. But there are, of course, other areas as well that have fairly high nociceptor density. Now look at this nerve. That is the suprascapular nerve. Okay, and you can see that a large amount of the supply of the nociceptors are coming from that nerve. Now we've got other nerves as well. We've got this nerve here, wrapping around the head of the humerus and creeping outside. That is the axillary nerve. And then up here, we've got the lateral pectoral, or I should say the acromial branches of the lateral pectoral nerve. Those are the three nerves that are supplying our shoulder joint with pain sensation. Of course, in terms of pain, we're going to go through basics first of all. I'm going to briefly touch on these things and talk about a bit about this. Prolotherapy, injection of dextrose. Big fashion for it a few years ago. It's supposed to have restorative properties. Nonsense. Bunkum. Don't use it. No good clinical evidence for the use of prolotherapy, certainly not in back pain and not in shoulder pain. So depending on what type of source of pain you have, what can you do? Well, with adhesive capsulitis, early injection is fine. It might help hydrodilation, maybe, but often they need a block. And really same with glenohumeral joint pain, radiofrequency denervation is what I do, and I'll talk about that. And then with needling, so the surgeons will do that, and impingement, again, possibly there is a role for tendinopathy with platelet-rich plasma. PRP, again, has been used for all sorts of indications. there isn't very good evidence for it. Perhaps with lateral epicondylitis, there's some evidence, and possibly weak evidence for rotator cuff tendinopathy, but really, it's not something that I would recommend. So let's go on to stuff that I would recommend. So when I started on my pain journey, we had these patients that got a lot of shoulder pain. What are we going to do? We're going to find the main nerve that provides pain sensation to the shoulder. So that's the suprascapular nerve. Coming off C5 and 6, traveling through the suprascapular notch, and then going down into the sphenoglenoid notch. Does anyone do the suprascapular nerve blocks here? I don't know how many of you do. Great, fantastic. So very simple block to do. You could do it as an anaesthetist. If you're doing simple decompression, post-operatively reduces your opioid requirement. I do them all under ultrasound, very easy to do. You see the poroid process, you see the dip, and you'll see the pulsating artery, and you can go either out of plane straight down onto bone, or you can go medial to lateral in plane to go down into that pity hip bone. You inject, you can see the ligament, the transverse scapular ligament, which is this one here, lifting up, and you're in the right spot. And I do radiofrequency denervation for these. That worked in some patients, but a lot of them come back and say, "Doc, they didn't work at all." So I thought, okay, what next? Let's look at those two other nerves. Lateral pectoral nerve. So again, ultrasound guided. Remember, the lateral pectoral, what we're talking about is the auricular branches of the lateral pectoral nerve. Some of you may be doing PECS blocks, chest wall. That involves the lateral pectoral nerve as well as the medial pectoral nerve. Those are more distal branches. These are more proximal, and they're going off to supply the shoulder, like I showed you earlier. Again, very easy to do with ultrasound. You place the ultrasound probe like this. You have your clavicle in front and your choroid plexus behind, and what you see is this gap between the two bones. There's two cliffs dropping off here. You'll see your ligament, the clavicular ligament going across, and you'll see a small artery within the neurovascular bundle, out of plane, very, very shallow, usually about 2 centimeters, 2.5 centimeters in depth. Very easy to do. Okay, so that's suprascapular, lateral pectoral, and the third one was axillary. So now the axillary nerve, so coming off the posterior cord, 3 main branches, anterior, posterior. We're interested in third branch, the articular branch, which is going up and supplying our joint over here. Again, simple block to do. Superficial, over the humeral head, scan in this plane, like so. Look for the artery, the circumflex artery, which is very, very close to the axillary nerve. And I go out of plane. It's about 2 centimeters, 2.5 centimeters down, and inject a small quantity. And again, at radio frequency. So I was then thinking, went from suprascapular, then I did a triple block, suprascapular, lateral pectoral, axillary. But a few patients would come back and said, "I'm sorry, that didn't help. What to do next?" So this is a lesson about read posters at meetings. Read the posters at meetings. When I go to a meeting, I read those e-posters, because I picked this up on a poster at a meeting in Israel about 4 years ago. This is the superior trunk block. So the superior trunk is this thing here. So much more distal than where you may be used to doing the interscaling block. And this supplies the area really interesting, because often shoulder pain radiates down into the forearm as well. And let me show you how I do this block. Right, you know how to do an interscaling block, common block that we all do. Yeah. So with an interscaling block, this is where you're placing your probe. You've got your anterior scaling, your middle scaling. You see the traffic lights in between. C7 down there, 6 and 5 over here. Now, if you move your probe in a more forward direction, you see this. Okay, so what we see now is we see coalescence here. And we see this nerve, the suprascapular nerve, drift off and go over omohyoid muscle. And what I tend to do is I block the superior trunk at this level. The thing to be aware of is switch your headlights on. Put your Doppler. Doppler is the headlights of your ultrasound, because you've got the transverse cervical artery there that may or may not be in your way. Now I bring the needle in and inject around there. I do maybe pulse radio frequency, but you could do this for shoulder surgery as well. 15 mils of 0.25% bupivacaine, maybe some dexamethasone if you believe in that. And so I moved on those patients that failed suprascapular, that failed the triple block, to doing the superior trunk block, pulsed radiofrequency. So why do I do it? Well, you get very good analgesia from it. Actually, some studies suggest that it's equipotent to an interscalene block. I've never done surgery using this, but I have seen plenty of patients that have benefited. And of course, the big advantage is you don't block the phrenic nerve. Likelihood of blocking a phrenic nerve in the interscalene block is very, very high. With this, less than 5%. Reduce nerve injury, because of course the sheath is much thicker as you go distally, so that's another advantage. Less risk of the injury to the dorsoscapular nerve. That's running through the middle scalene. And therefore there is a risk as you go through, you'll hit it, as well as the long thoracic. 2, sometimes you get anomalous C5 anatomy, but that is important if you're doing an interscalene, not important if you're targeting the superior trunk. How do I do it? Patient is lying on a pillow, head turned to one side. I use a short 5 centimeter radiofrequency needle. You can use a short regional anesthesia needle. Pulse them for 6 minutes. And because I'm just doing pulse radiofrequency, I'm using low volumes. If you're doing this as a block for surgery, you would use larger volumes. Of course, the duration of effect is dependent on volume and concentration. So if I was doing this as a block for surgery, I'd put in 15 mil from off. Watch for your arteries, really important. If you're doing this, watch for that transverse cervical. Put your headlights on. Right, that is it. I beat the bell, which is good.
Thank you, Dr. Which for non-pain practicing anesthetist, not non-chronic pain practicing anesthetist like me, kept me engaged as well. Thank you. We'll have the question and answer session now. So the house is open for questions. Please, whoever has a question, please introduce yourself and then ask the question. Dr. Wazir, please. Thank you.
I am Dr. Smahan, anesthesia consultant from Shaukat Khanum. So I have a question from Fawzia. Thank you very much for the very nice talk. And we don't know the role of the simulation at technical and non-technical skill development and trainees. But what is your experience of teaching non-technical skills as a faculty member of CAST program? And second part of my question is that how can that faculty help the low resource income institutes to develop those, to develop the scenarios and the faculty in our setups?
Thanks so much, Asma, for asking me this question about how we can develop technical and non-technical skills. Being a faculty as a CAST founder for the last 10 years, I have learned that there are the scenarios which are not common in the daily life or in a daily anesthesia practice. So with the help of especially Basket 1 and Basket 2, which is the multidisciplinary course where the faculty or the trainees from the different departments are participating. So what I have seen, the improvement is how they develop the leadership role, because during the course, it's a loop communication, and during those courses, there's someone who's taking the leadership role, there's someone who's acting as a team player, and then how they can swap the role. So those trainees who are doing all these courses, I can see they can work in time. They know who the leader is when some crisis happen in the real life or during the real scenarios. Just for example, we dealt with anaphylaxis just recently in the theater, and to my surprise, there was one person who just came in and rang the bell straight away to call for the help for everyone. It's a terrible sometimes as a consultant, we feel that if we call for help when we are consultant, it's not a good thing. But that new consultant was going through all the 10 courses, and he knows that calling for help is not a taboo. Though you are a consultant, you're a lead, but still you need a pair of hands, right? The pair of hands is really important in a crisis. The second thing is they ask for the guideline and the framework, how you are going through the whole algorithm. So, how to call for help and when to call for help in the right time, and then the leadership role is to just ask for the algorithm straight away and then follow the algorithm, then dedicating a task to one and another, and then asking them to loop communication that, yes, this was my task and I have done that task. Communicate back to the leader that I got that task and have completed that task. So, and then the situation awareness again. So on the right time, it was diagnosed, what was happening, call for the help. Then again, after calling for the help, dedicating the task and doing as a teamwork and doing the decision on the right time. So that was my experience, was that, how to deal with. These are the skills like leadership, teamwork, communication, and situation awareness. And really, the simulation really helps to develop all these skills. And there was a paper in 2019 in BMJ simulation, which shows that, yes, simulation does help to develop all these non-technical skills. Your next question was how the low-income hospitals like Shaukat Khanum or the low-income countries, how they are going to develop the simulation. Now, the main thing here is to develop the scenarios which are important to your team, or which is important locally, the case means. So development of the scenarios and the framework is more important than acquiring a big simulator or high fidelity simulator. So even if you don't have any manicum or simulator, these hospitals of low-income countries can start with the just actors, right? That you develop the scenarios and you you can ask someone to act on them. So start from there and then move on towards the manicum and the simulator. That's what I suggest.
Thank you. Thank you so much.
My name is Dr. Shahidar. I am from Gurji Trust Teaching Hospital, Lahore. My first question is from Dr. Fawzia. Cognitive aids, how can they help in managing certain situations, emergency situations in lower income countries like in our setups? How can they help? They're not as much adequately available in our centers. And the second question is for Dr. Mahajir. The role of alcoholic neurolysis and shoulder pains. Is there any?
So, as I mentioned, while answering Dr. Asma's case, that the simulation, with the low-income countries, you don't need a big simulator to buy, and you can start with the scenarios and develop the faculty. Development of the faculty is again very important. So once you develop a faculty by the training course, again, this faculty can be developed on just to develop the scenarios and how you are going to act in the emergency situation. So for example, the malignant hypothermia is a very rare case. If it happens really in the real life, how your trainee is going to respond to that. So just developable scenarios that if it happens, how you are going to recognize the situation, what are the signs and symptoms. You just develop scenario based first, right? When are you going to call for help? When are you going to follow the algorithm? And how you're going to, step-by-step approach. So that's the way you are going to develop all the cognitive skills and tools.
Before we go to the Dr. Mahajir, can I just ask you another question just related to this? How do you motivate the faculty to take part in this and making these scenarios? Is it part of their annual evaluation? Are they given a task, or is it just voluntary? Because this is a problem in the service models that is practiced in the hospitals here, especially private universities.
In Ireland and I think as far as I know, in the UK, there's a dedicated time, which we call it the non-clinical days. And these non-clinical days are utilized to do all these non-clinical activities. However, still all this work is voluntary basis and on the interest base. So I have never been, I would say, was given an extra incentive to go into the simulation. It's voluntary based, it's interest based, and then utilization of your non-clinical days. So everybody has their own interest. So the trainer course in Ireland is, every month there is a trainer course by the College of Anaesthetists. And I think there may be 20 consultants attending every month, but hardly, 5 or 6 are volunteer at the end of the year. So it is difficult, but again, if keep going, doing the process, to keep and retain the field.
Dr. Baloch, can you answer the question?
Yeah, really thanks for asking the question. It's an interesting question because I know that I'm used to using radio frequency probes, and that might be available to you. First declaration, I've never done chemical neurolysis for any nerve whatsoever. So since I was a trainee, it's all been radio frequency. Second thing is that what I'm doing here is what's called pulsed radio frequency, which is non-destructive. Why? Because I couldn't do that in the superior trunk. Otherwise, I would render the muscles of the upper limb paralyzed. The third thing is, of course, the risk would be around spread of collateral structures when you do chemical neurolysis. So I'd be interested to know from your own perspective, is this something that you have done?
Like suprascapular nerves, we have done some cases with chemical neurolysis. They have very good results. In suprascapular nerve, we have done some cases because it mostly supplies 80% of the shoulders, and the patient pain is relieved.
Lena from Kurki Hospital. Dr. Baloch, our practice is to do the suprascapular and the axillary for the shoulder work. I want to know, do you recommend to do the lateral pectoral in one go, or do we wait for it to be a little chronic?
So my practice now is to do the 3 in one, all 3.
I know on the internet for fees, I can tell you it's PD Crisis. It's an app, you can download it. We have personally, I think they have 20 scenarios, including NFI-Lexis. So as soon as we have a crisis, we say, okay, open the app, and then we make sure that we follow that.
Thank you so much. If you have any other questions, I think they can be asked after the session. One more question. So one last question before we start the next activity.
Yes, please. Dr. Zaida, thank you so much again for presenting this talk. Just one quick question. We have in the recent times, we have a lot more cases of uncorrected hearts, which are coming in for a shorter procedures only, like for MRIs, for CTs, and for ITs. Any, I would say, a very quick clue or anything we would like to tell us to our residents, please, how can they save themselves? Thank you.
Choose your patients wisely. I think look at your, not every, what kind of procedures are they coming for?
So IT chemotherapy, CT scans, for sedations. for IV chemotherapies, for MRIs, for sedation. And sometimes, like by the time they are there for a bigger procedure, we have sorted them out. But like once they come in, they are being fast tracked for smaller procedures. For sedation. Thank you. We have done that already.
So I would say I would, if I was working at Shaukat and somebody was asking me to get a CT angio on cyanotic unrepaired heart or single ventricle physiology, I would be really wary of that. Anybody with significant lesion, I would send, and I can tell you there are centers around in this city that are doing that, and I would send it to them. Because not only do you have to take care of the patient for that procedure, you also have to manage any complication.
I would love to have that collaboration with children.
We don't want more patients.
We have things that are it's just I would just like to introduce. I will be opening our panel discussion on an interesting topic, and I would like to introduce Dr. Irfan Yusuf, who's here. He's our neurosurgeon in Khanum. He has done his training in Ireland, and I don't know how long he's here, but we find him very helpful, a very helping hand. Thank you so much for being here, Dr. Irfan. Thank you so much. Introduce yourself as well.
This one and the
Good afternoon, everyone. Assalamu alaikum. My name is Dr. Basma, and I'm working as a fellow in Department of Anaesthesia here at SKM Lahore. Today, it's my utmost pleasure to moderate this session, Timely Transitions, Rethinking Work, Appraisal, and the Future of Anesthetists. Let me introduce you to our esteemed panelists, Dr. Irfan Yusuf, consultant neurosurgeon at SKM Lahore, Dr. Saida Asif, Dr. Huma Salim, Dr. Fazia Khan, Dr. Fazia Bano, and Dr. Mujib Baloch. I'll guide the conversation through different sections. Panelists, please feel free to share your opinions, and audience members, keep your reflections ready for later. Let's begin from the start of our journey, that's training and early careering. Dr. Irfan, I would like to ask you, do training programs truly prepare doctors to step into independent practice the day they finish?
question.
It's on.
So, talking about neurosurgery, it's a huge field. When it comes to training, we're up to a certain mark when we leave our training. Over the time, initially it was just FRCS neurosurgery, and that was it. We go out and read and do whatever we had taught and learn on our way up the ladder. Now, the training has become exceedingly structured. And it's a matter of, a self-realization. What can I do safely? Where do I need to learn? Where do I need to get down? And how do I progress and reach a level where one is in a position to manage the more complex situations? So it's a continuous process. Getting out after certification is just the beginning, I would say.
Thank you very much, sir, for your input. Dr. Huma, I would like to ask you, when junior consultants are posted to peripheral or unsupported settings, do they get the mentoring they require, or are they left to figure out things on their own?
Unfortunately, till now, the mentoring system is not that well developed in our circumstances. So, in smaller setups and smaller chunks, we are trying to introduce that system. We are trying to groom residents into becoming young consultants. I would not use the term junior consultant, because I think we are all in a lifelong learning process. But then when we are young and we are new to these surroundings, then yes, we do need mentorship. And if these mentorship programs are introduced at national level, they might help us a bit more. But right now we are doing it in chunks and bits, and I hope that will help us for providing a cover for some time, but we need consolidated national level efforts like our esteemed speakers here, Dr. Fawzia here, who is a much better person for involving national and worldwide support for that. But I think, yes, if mentoring is available, it will help us to guide through and navigate through the earlier parts of our careers and stuff.
Great. So I would like to ask Dr. Fawzia Khan, can you please quote us examples where mentoring made a big difference?
I think mentoring to some extent is present in all our institutions, but it's very informal. And nowadays, there's a more role of a formal mentorship. We introduced that in our own university about 5 years ago. We introduced a mentorship program, but this was for the new entrants, for all new faculty. They were offered a mentorship program, and they were given the choice of 3 mentors, and they could choose whichever mentor they wanted. So that has been very successful. 2 years ago, it was open to all the faculty. So I would vouch for mentoring. Mentoring does have a role. Formal mentoring does have a role, but the choice should be the mentees whom they want to choose. And also more than one mentors. There should be availability of more, like someone wants to progress in the career, or someone wants to progress in research, or in other things, then there should be a choice of different kind of mentors available.
Thank you, ma'am. So coming to Dr. Saida, I ask you, ma'am, how satisfied are new consultants with the pay and incentives that are being offered in peripheral setups? Yes, ma'am. Or even abroad as well. You may quote both of your opinions.
Yeah, because I practice at both places, so I will say this. I feel for my comrades in Pakistan, especially those who work in government hospitals, because they have to do 2 jobs at minimum to support their families. And I think it's, I don't think, and I think that's why we're losing so many of our physicians. Is because we're not paying them in. I think in the United States, you're paid very well, but you work very hard. I think for people coming from UK or other non-US locations, I think it's a very different culture.
Thank you. Now let's think about the bigger system around consultants. Dr. Fawzia Bano, may I ask you, in peripheral setups, are strong backup systems in place, or does patient care mainly depends on referrals?
Again, I would say, are you asking about the situation in Pakistan or the situation where I worked? Since I left in 2006, I'm not aware of too much, what the situation is, especially here. But I do presume still, while talking to my own colleagues who are here, I don't think so. There's adequate referral system here in Pakistan. While working in Ireland, what we have learned, or I have learned at the moment, is there's a central referral system. So if we have some patient, we know where we do need to refer them. So if I have someone with neurotrauma, I have some pediatric cases with any cardiac lesion, I know there's a central system. If in intensive care, even I have someone, there is again a central system where to refer them. So I think we do need to develop the same type of central system in Pakistan, where even at the provincial level as well, that these are the patients which we can't treat here, and this is the center which we need to go.
I would like to refer this question to Dr. Sneha as well. How do you actually find the referral system in Pakistan regarding your pediatric population, the kind of patients you see them have? What is your experience from the region regarding the referrals you get, the kind of optimization they have had beforehand or anything like that?
So I'll compare that to two different kinds of hospital within law. So at Children's Hospital, it's a hospital where you have 5 patients on a single bed. And I'm not joking. So imagine taking your child because you don't have the money to go to a private hospital. You have to share that bed. It's our referral system. I once did an informal survey. People are driving or coming from 5, 6, 8 hours away. People come from Afghanistan before the border closed because they didn't have the services. So unfortunately, our tertiary care services are very Lahore based in Punjab. There are very few centers and I'm talking about pediatrics. There are very few centers outside of Lahore that are doing complex pediatric care, surgical care. And so that's what our referral system is. People are coming from very, very far away. They cannot even afford the fare. Now let's compare. Those patients are coming in. They are not at all resuscitated. Sometimes they arrive dead. They have traveled 8 hours with a dead child, or the child dies within a few hours of arrival. Let's go to one of the private hospitals in town where they do peds cardiac surgery. They're the kind of patients that they get are very different. Patients are still coming from far away. WhatsApp is a lovely thing. The surgeon can get their echo, their cath lab reports and everything. They can tell them, okay, come in so-and-so date, we'll get this all redone, and then we'll schedule them for surgery. But the kind of care and the kind of referral that we're getting depends on the patient's socioeconomic background.
Very well said. So coming on to Dr. Mojid. Sir, can you please guide us through the tier system that exists between senior and junior consultants? You see this hierarchy as beneficial? You think it supports growth? Or is it just competition?
So I can only speak about the UK system, not about Pakistan.
Yes, please.
So is there hierarchy? Of course there is, yeah. There is inevitably hierarchy because they are learning and we are their teachers. I think there is more equity there. I mean, for example, I'll give you a small example where our residents call us by our first name, as an example. Certainly in Anaesthesia, there is one-to-one teaching. So that helps. Whenever there's a consultant doing a list, there's always a resident with them. So that, I suppose, breaks the boundaries as well. Then so our department is very convivial. So every year the department hosts a ball. So all the juniors are invited to that. And then regularly during the year, there are various social events. For example, we have a sports day with the residents and the consultants come and play games or whatever. So we try and make it as, I suppose, friendly, but nonetheless, inevitably there is going to be a senior and junior aspect to it. I think it works quite well. I think the junior's quite happy with that aspect. There are other aspects that they're not happy with, which I won't go into. But in terms of tiering, it's never been a big issue.
Thank you. So,
Staying applied to surgical projects as well, do you think a hierarchy would benefit the surgical colleagues as well in the similar manner, or is it a bit different there?
Yes, we call it hierarchy, but it's actually mentorship. And we take somebody as a teacher, and it's up to the learner as a teacher to develop that record, where they're working at a tier, but they're working together. And it's a matter of, we were discussing just yesterday, it's a matter of passing the baton early on in the training, rather than keeping that barrier all the way along in the teaching program. And that's where the knowledge and the expertise is handed over in a graded but progressive fashion, without even knowing that we're working at a different level. So once the teacher feels that, yes, my trainee has got the snaps, this is done, we move on to the next. Having said that, the teacher will always be in the background, assessing, evaluating, and imparting those issues of information and expertise that he thinks need to be inculcated. So, it's a matter of grooming. How do we establish that relationship? I believe where every teacher and every student varies in their intellect, in their culture, and in their personality. Sometimes there's a little bit of friction. If I am teaching somebody and my resident says, I think, you can say this fine, and I take that, okay, I'll be calmer next time. So it's a matter of assessing each other rather than the teacher assessing the resident. It's the resident assessing the trainer as well, and I think that has been really included in the teaching programs in UK, Ireland, and America, where the trainer is actually assessing the and that feedback goes to positive ways. It's not negative. It's actually coming up and clearing those barriers which are hindering the training process.
It is taken from there. I think things have changed over the years. When we started our training, there was a huge barrier between the teacher and the learner, but things have improved. Just an anecdote, where I trained in UK, the neurosurgeon there was called the God. They are gods. But talking about feedback from the trainers, we've had that in a department for a long, long time. And, it does not work that well as it appears on paper. Because, our culture is different. People are still afraid, though it's anonymous, but people are still afraid of saying anything against a senior person.
Very right. Okay, so Dr. Huma, how transparent and needs-driven is consultant hiring, both in public and private setups, as you work in both systems?
So I think the drive with the need for hiring new consultants was very elaborate through the talks that we had just now. So we need to have dedicated teachers. We need to have dedicated people for super specialties like pediatric, cardiac, anesthesiologists. How many of them are there? This is the need of the hour to train and to incorporate them into the system, both in the private and the public sector. So I think the need needs to be recognized. The need can be recognized only if we need to conduct researches and surveys on our own levels wherever we are. Actually, I think every little helps. Every little data that you collect is a meaningful number, and those meaningful numbers can add up and help formulate the national policies as well. So if we can find the right kind of people and we can actually formulate a plan to them, then it will be easier for them to actually understand what we actually mean through need. It is not only one person needed. We need educators, we need anesthesiologists, we need team players, we need leaders. We need everybody on board. So I think the need of the hour is not defined to only one specialty or one super specialty or one specialty. It has to be unanimous. It has to be driven by the health sector itself. And it has to include not only the doctors or the anesthesiologists, but the entire healthcare team.
To this. Unfortunately, I will say this, in the public sector, the hiring is not merit-based always. There are a lot of political and administrative pressures, and actually they make the list. So I can, let's say for 40 medical officers, interviewed 4,000 people, thought I'll call everybody American style and find out this is my list, and I will call their references and find out and make a list. But guess what? I find out the list we had made for anesthesia. I got a very different list. I had no input on that list. We are short of people that left.
We are anticipating, we've already lost 20% of our workforce. We're anticipating another 25% workforce loss. But unfortunately, in Pakistan right now, we're being told we cannot do any hiring at the government level. So we've been told, don't come to us. You've got to run all these wars, but don't come to us and ask for more money.
Very right. Thank you for your valuable input. Contracts are the foundation of any job. So now to examine them, I would like to ask Dr. Fawzia Khan, what goes into a consultant's contract? Are duties, hours, pay, incentives clearly defined or left vague?
No, they should never be left vague. I've never worked in the government system, to be truthful. I started in Pakistan. I started with Yar Khan University, and I've been there till my retirement. So the system there was very different. The contract clearly identified what was the clinical commitment. We were very fortunate that from the beginning, we had 20 to 30% of the time given as non-clinical time to deal with teaching and research. And that's helped a lot in the career progression of all of us, including myself. There was also pressure from the university about research, and we could never say no because the time was there. Nowadays, there is also financial compensation for some of the things. So this should all be clearly specified in the contract.
Very right. So, Dr. Mojib, from your perspective, what are the most important factors when deciding to sign a contract?
Read it thoroughly and then read it again. I mean, it's interesting you were saying, I mean, in our contract, there's a job plan. Monday AM, we're doing this for this many hours. Maybe Thursday PM, we're doing this. So it's in black and white, and they hold us to task on that. So on the basis of that, we work a certain number of hours, and that's what we're paid for. We can't be expected to work beyond that hours, but we are expected to be in the hospital on site in the hours that we're supposed to be. And that's a legally binding document. Pay terms and conditions and whatnot. We have a trades union that deals with that aspect of the contractual agreement. I don't know whether in Pakistan there was a trades union, is it? No. So, okay. Well, I won't go there. Anyway, that's why. So if I'm applying for a new job and I'm unsure about what is the contents of the contract, I would send it to my trades union because they have set people that look at these things. For example, at the moment, the juniors are in dispute. People that are organizing the strikes, which are going to happen in the next couple of weeks, around terms and conditions in the contract. That is the medical union. So, it does give them power because, of course, being part of a union means that you can demand you think is fair, whether they the government succumbs to that is a different matter. But there are some things that one just has to accept are going to be in the contract, and you're going to, if you've read it and you've signed it, you're just going to have to accept. And if you don't agree with them, then don't sign it, negotiate. And we may be coming to appraisal, and that's the time that I negotiate my job plan on a yearly basis.
So, Dr. Fawzia Banu, can I ask to take this conversation further? What mechanisms should exist to safeguard consultant well-being? Workload, rest, psychological support, and all that sense.
Yeah. And working in Ireland since the pandemic, I think person well-being is one of the aspects which is being looked after at the NCHD levels, that the non-hospital consultant doctors, which we call resident as well, or the junior doctors, as well as the consultants as well. There are the lectures on person's well-being at the national level, which are conducted in this room, how the well-being should be and how can we address it. There are the well-being breakfast, which is the date is centrally organized by the College of Anesthesiologists who are our resident, and it's being conducted at all the regional hospitals. I think at those well-being breakfasts, we do discuss with our juniors or NCHTs, what they would want, what they are feeling bad, what they are feeling good at those. And they are given the freedom to speak about it. If they are not, if they are feeling stressed about something, they do discuss. And if they are feeling good about it, they discuss as well. Beside that, they are mentors for all the NCHDs, and they've been getting freedom about it to discuss even their any aspect at the family levels as well, because when someone coming new in the country, even the Irish resident themselves, they do have some family issues, and they are given the freedom to talk about any family aspect as well, to talk about it as well. Beside that, there is occupational health. If any psychological issues or any other issues going on, there's a system to refer them. I think such type of support can help to support, the well-being.
Thank you, ma'am. Thank you, ma'am. So our next section is about growth and development. Medicine evolves. So talk about keeping pace. Dr. Huma, how many opportunities do consultants realistically get to learn new techniques and subspecialties?
Can I please direct this question to our esteemed faculty who is here as part of our attendees here, Dr. Attar and Dr. Khalid Zawad. They are here. Dr. Leena, can you please put your kind input into this panel discussion as well? Just help us through this question answer navigation and just help our younger colleagues to understand this matter a bit more.
Thank you very much for giving us the opportunity to talk about something. Well, this is not about professional growth. We heard a lot about learning analysts about the mentorship and the preceptorship. I think one of the most important aspects is that leading as a role model, and in the growth of our trainees as professional leaders in the forthcoming world. So that is really something which is really a big challenge for all of us, that how do we fulfill that role as a mentor for our trainees. And that is something that on which we should work hard, because not everyone is coming from a similar sort of background as far as their moral ethics are concerned, as far as their personality grooming is concerned. So how do we foresee our future cohort of consultant anesthesiologists to be an excellent human being, an excellent anesthesiologist, and an excellent professional? I think this is something which is of most concern to me.
Dr. Khalid, can you please elaborate on this phenomenon of brain drain which is happening despite...
Let me talk my own words.
Yeah.
First thing, I see the first question was asked by the Dr. Saida. The main problem is of the resident. The economic issue is of the resident, not the professor, assistant professor. बड़ी पुरानी बात है, मैंने इस हाथ से पूछा, मैं उसमें था कि प्रेजेंटेशन की फीस थी या क्या था, वो आगे से मुझे जवाब ये मिला था कि यार if you are not affording, don't join the specialty. आपने देखा होगा कई सुसाइड हुए. मेन इश्यू वाज इकोनॉमिक्स, और इकोनॉमिक्स किसकी थी? जूनियर रेजिडेंट बेचारे दो ड्यूटियां करते, तीन ड्यूटियां करते, और उनके माशी हालात फिर भी ठीक नहीं होते. द मेन इशू इज ऑफ द वेजेस ऑफ द जूनियर. दूसरा जो मैंने देखा है, पीपल हैव लेफ्ट स्टडीइंग द टेक्स्ट बुक. मैं अपने जमाने में मैंने कभी पार्ट 1 के बारे में सोचा भी नहीं था कि मैं टेक्स्ट के बगैर. अब नोबडी नोज के लिए कौन सी किताब है फिजियोलॉजी की, कौन सी किताब है एनाटॉमी की, कौन सी किताब है पैथोलॉजी की. आस्क देम, दे आर नॉट नो दी टेक्स्ट बुक में वो क्या करते हैं MCQ पढ़ते MCQ which are not reliable written by the even मगर ऐसी कैपेबिलिटी भी नहीं जिन्होंने लिखी तो ये टेक्स्ट बुक पढ़ना छोड़ देना आर्टिफिशियल इंटेलिजेंस ठीक है एक आपके पास एक्सेस टू द नॉलेज जो है ना वो बहुत आसान हो गया एक और चीज है टीचर जो है हमेशा अपनी तैयारी करके आया था तो रात को तैयार करता था अब USB लेते हैं उसमें डाउनलोड करके ले जाते हैं वो उसके ऊपर तो ये दीज आर द थिंग्स मैं अपने हाथ से अपनी डेजर्टेशन लिखी हम लिख के लेके जाते थे टाइप करते थे गलतियां निकलती थी अब आप किसी रेजिडेंट को पूछ लें उसने पैसे दे के लिखवाई होती तो इस तरह के ये जो इट्स ट्रू मैंने कई बंद और एक और चीज जो करते हैं सर आज मेरा आखिरी दिन है ये मेरी थीसिस है इसके ऊपर साइन कर दें वरना मेरे 6 महीने रह गए मैं उसको कहता टॉपिक ही बता रहा तो ये देयर प्रॉब्लम्स दीज आर प्रोफेशनल और इनके बारे में उनकी वेजेस के बारे में सोचना चाहिए उनसे आवर्स पूरे कराने चाहिए जिसमें सुपरवाइजर का भी रोल है यू शुड सुपरवाइज योर रेजिडेंट एवरी डे एंड यू शुड आस्क अबाउट दी उनकी जो नॉलेज है प्रैक्टिकल नॉलेज है थ्योरेटिकल नॉलेज है उसको सुपरवाइज करना भी हमारी जिम्मेदारी
Thank you, sir. So consultancy is demanding in balanced matters. I would like to ask Dr. Saida, are flexible hours or part-time options realistically available for female consultants? And have you seen examples where flexibility made a career sustainable?
They would take care of their parents in Pakistan and work in the United States because of their recognition that they need a physician, and it's a market force. So yes, you can have a balance, but here's what I would say. I think I want to address another thing that you asked. I think one of my main blessings in life was I ended up for my first job at UNC, and I had selfless mentors. So as a young attending, you were asking about learning curve. So you have a learning curve when you start your anesthesia residency. You know nothing, and then you learn everything in a very steep curve. So in the United States, they say when you become a consultant, you become an intern all over, and that's how your learning curve is. So if you are not willing to work in those first 5 years, my mentor told me, you can decide what kind of attendant you're going to become. Are you going to become somebody who tries to run away from the difficult cases? Or are you going to say, okay, these are the cases, I'm going to do them, and you're going to gain experience and you're going to grow? So your first job, look for a job that gives you a good mentor who's able to protect you, because no matter how good you are, if you have a complication in your first 5 years, it can be a career-changing mistake, especially in the United States. So try to avoid that. Pick up a place that will back you up, will teach you. It will be a place where you can grow, and then never stop growing. If you have learned everything that was there to learn at one place, move to a different place.
Dr. Fauziya has something to say.
It is about the job sharing that you said. Yes, that is, the example was there when I was in UK. There were certain posts kept for females where they could job share. So 2 persons could share one job and then give people plenty of time, those with very young children. You know, the problem with females is their career and their biology, that, you know, you have to come to terms with that. So people have to choose either giving up their career or delaying their family. So that becomes a problem. So job sharing gives this opportunity. But the problem is, ये हमने अपने इंस्टीट्यूशन में बहुत लड़वड़ के एक जॉब करवाई थी जो जॉब शेयरिंग के लिए. It was utilized, but then there is a problem. उसके बाद जो कुछ और लोग थे, they were not interested because it increases your training time. So instead of 4 years, it takes you 8 years to complete your training.
Don't you think 8 years is worthwhile then totally leave it for the ladies to, especially now
now we have a preponderance of female doctors.
But it depends on the person who wants to do it. You can't really force them.
No, the system has also been.
They do. That's fine. I mean, try to introduce it, especially in private institutions. If you can do it, and there are two persons who want to share the job. Fine.
I'm so sorry. I've never had this 8-year training thing, but I will tell you this. Civil hospital के अंदर I've had trainings with multiple pregnancies, training to have 8 साल की गरीबी तो नहीं होती, लेकिन 6 तो पहुंच गई. I think it's a disservice. Frankly speaking, it's a disservice. आपने अपनी training करनी है, expect time period. It's only 4 years out of your life. I'm not asking you to give me 10 years. I'm asking you to give me 4 years. I had a child during my residency, my first child. I decided nothing doing, not having another baby till I'm done with my training. What's the problem?
No, Dr. Zaiba.
I mean, having a lot of kids on your hands, especially in Pakistan, where you do not have good support in your house. The doctor is supposed to go home, take care of her kids, cook for the entire family, and then come to work the next day. When she has a lot of kids, I can tell you it's physically and humanly impossible.
Thank you, ma'am. So, Dr. Fawzia Bano, can I ask you, should evaluations be outcome driven, or is there?
Okay.
I just wanted to add, it's not a race. It's not a race at all. You just need to focus on your priorities. Make a priority list. Usko banai. Please uske upar chale. Don't burdenize yourself. Just Dr. Khanum ne kaha, there's a lot of emotional baggage. There's a lot of mental health issue going on in our society, and this is not a competition. ये कोई मुकाबला नहीं है. आपको लगता है you want to do training, do it wholeheartedly. Give it your all. Be all in for it. But if you want to embrace motherhood, do it with all your full support, full mind, full emotional well-being as well. Because every task is not a task. सिर्फ एक task नहीं है. जैसे आप काम करने आते हैं, you have a patient who's a human, and at home you have a child who is a little human as well, who has his own requirements, who has his own emotional things you need to take care of. So at the same time, in सबके अंदर, you are also a human. So I think this is not a muqabla. This is not a competition. There is no timeline to success. You actually define your own timeline. So don't run after one another. Don't look to the other and say, oh, he has achieved so much. मेरे 8 साल हो गए हैं, ओहो. मेरे 10 साल नहीं हुए, ओहो. मैंने 4 साल में कर लिया, अब मैं क्या करूं? So it's all you. It's all about you. How you manage your life. Nobody is in charge of your life. And you're in charge of your own happiness. You need to maintain that happiness in life. Thank you.
Yeah, for the flexible career opportunity, I would say in Ireland, it's not the option, it is mandated. It's not only for female, it is available for male and female. Because it's not only the female who can have the issues and the problems in the family, it could be any male as well. So regardless of whether it's a male or it's a female, the flexible training opportunity is available to everyone who wants to avail it. And I did myself for a year at least. It's not the job sharing. All you need is to apply for the central system. That won't take flexible training, and that's it. Again, there is another very good facility available is the maternity leave. So once you have a baby, you are off for 6 months paid. And if you really want another 6 months, you get unpaid 6 months. And it's not counted as a team. So that's another thing which we can avail, and which here in Pakistan, we all should be looking forward that paid maternity leave should be given to all the female and unpaid another 6 months if they want it. So that's another thing. So I think and as at the consultant level as well, the flexible option is available. There's a full-time contract, just sign full-time contract. And then in your career in the life, you feel that you can't work full-time. There's an option available. You can, apply centrally that I'm not available full-time. I can't cope with my life. I want to go on part-time on a flexible hour. And then this option is available and it's mandated. They have to give you.
It's not that it's an option. Oh, if it's available, we're looking at it. It's available for everyone. So that's the thing. We don't have opportunity there in Ireland that we have household workers. We finish our work at work, then we come home, then we work as housemaid, we work as a cook, we work as a driver, then we work as a teacher and a tutor for the kids as well. So, and it's not for only us. When I will talk to any Irish female trainee or consultant, they will be saying the same thing, that, oh, I'm going to start the next job once I'm gone home. So we don't have a luxury of housemaid, cooks and drivers either. So that's why I think the flexible working hours and flexible contract is available for anyone and everyone who wants to wear it.
Thank you. Dr. Fawzia Khan, beyond clinical work, what non-clinical roles in leadership, policy, management should senior consultants be offered?
It's not just offered, it's also your choice. It's your choice. There was a big debate, or there's still debate about female leadership roles in academic institutions all over the उसमें ना choice पे भी depend करता है, लेकिन the opportunities should be there. There should be equal opportunities for people to go into schools. उसमें भी और दूसरे roles में भी opportunity होगी. One of the problems is, हम अपने postgraduate education जो है anesthesia में, उसमें हम clinical skills और उसके ऊपर focus करते हैं, but we do not focus on training them to leadership. Even safety. Safety बिल्कुल हमारे curriculum में mention है. अगर आप CPSP का curriculum देखें, उसमें सारा clinical का skills है और knowledge है और हम कुछ नाम टेस्ट करते हैं, उसको नाम हमको सिखाते हैं कि यहाँ से उन्होंने FCPS किया, वहाँ जाके referral hospital में they're in charge. They don't know, they're lost. They don't know what to do. तो वो वहाँ से problem शुरू होता है.
Right. So, Dr. Irfan, do you think that retirement planning in our setups is managed proactively, or it changes according to the hospital needs?
So short of that, I think we should make use of the best of our mind. With years, we mature, learn, we collaborate. We are sailing through the sea, and we're all there. So putting a line at 60, 65, 70, well, yes, the government has its agenda. They can't keep the young generation as strong, and they lose slots of consultants, new consultants. But we shouldn't lose whatever we have learned with that little label retirement. So we should continue to work. Of course, we should pre-plan our retirement, be it monetary, be it our social circle or our professional life. So one should be able to do what one is capable of doing at whatever age. And it's a self-realization, it's a personal choice, whether we should be out paying call for 20 hours a day or spend some time with the patients and earn a little. So there are a lot of things involved. And end of the day, yes, there should be planning. One should plan for the retirement well ahead of time. But there are certain terms in life which are very abrupt and sudden and at times very aggressive. Those events could be affecting ourselves or our families. So it's a difficult one, but it's an aging process, and we know there's an eventuality. Plan for it.
Thank you, sir.
Should never retire.
Never
It is a real change of place of duty. If Punjab government है या बाकी government है, यहाँ पे आपको वहाँ से करती है, but doctor, as doctor in progress is you become more valuable. The skill increases. And you should deliver what you have in knowledge and skill till the death. Only doctor can retire when he becomes mentally and physically incapacitated.
Yes, what about I asked my husband this question. Are you ever planning to retire? Because I could not retire.
Before we wrap it up,
मैंने एक चीज देखी है सॉरी कि मैं कॉर्पोरेट स्टेशन में काम करता हूँ तो जब मैं आता जाता हूँ सोच में people become very happy when there is a holiday. तो इधर कुछ होते हैं मैंने कहा यार सारी उम्र आपने you have a long, very long life after death. You sleep as long as you. God.
Thank you so much. I would like to thank the esteemed secretary, the panel members, and Dr. Dr. Oscar, Dr. Sayyid for our time. Irfan for joining us as a surgeon in our entire modern anesthesia. Thank you so much, sir. And I would like to thank our attendees as well who are here with the session, what it is, and who are here. And I hope we actually gathered something. It was somehow beneficial to you. It somehow resonated to you. And we look forward to see you again next year when we host another session of onco anesthesia in the next coming year of 2020. Thank you so very much.
thank you, everybody.